Thank you for inviting me for this talk today. So these are my disclosures. The objectives of my talk, at the end, we're going to talk, the first half is going to be structured a little bit about what type of resources are necessary to design, implement, and maintain an ERAS program. And then the second part will focus a little about what the existing evidence is and how it's applicable to one's own institution. So any part of building a business case when we're bringing this topic up to administrators is really trying to balance out the upfront implementation costs with what potential savings that we're expected to see. And I'm not going to harp too much about this because we have many talks about this, and I think Dr. Feldman and Dr. Carley have kind of talked a lot about this already, but the type of resources that are necessary to make these programs work is really we need a multidisciplinary steering, we need a group of people, of surgeon champion, anesthesia champion, nursing, admitting, all of these champions from all of these different faculties. We need an ERAS facilitator, so at our institution it's an ERAS nurse. We need some sort of patient education material as that's been shown to be very important for a successful enhanced recovery pathway, and we're going to need some sort of clinical audit and feedback. So again, part of our steering group at the MUHC is organize something called the Surgical and Recovery Program, sure. So I'm always a little bit hesitant to kind of show this slide because it kind of it shows us what the fee schedule is in Quebec. So it's sometimes a little bit embarrassing to show this, but overall, when we look at the time costs of the people that are participating in this, and we meet around 1 hour once or twice a month, and it turns out based on the hourly salaries and what other opportunity costs the surgeon or the anesthetist could otherwise be doing, it turns out to be around $500 per meeting in terms of time costs. And most importantly, the yearly salary of our dedicated ERAS nurse coordinator, Debbie Watson, and who was very gracious to let me publish her full salary, so has earned around $80,000. So these are probably the most important types of resources that are available, that are required. During our meeting, again, Dr. Feldman has touched upon this already. We look at the available evidence, we try to establish consensus between all of the involved stakeholders, and we try to put that into practice. And sometimes it's not always obvious, and again, when we look, one of the major roadblocks that we've had in the initial implementation of a lot of these programs is actually with just the admitting office. And again, that's where patients would show up to the operating room in the morning, and despite us saying you can drink, take these carbohydrate drinks, they've always, almost all of them initially said they were fasting and they didn't take these carbohydrate drinks. And it's because admitting, whenever they've been called for scheduling, has always been told to be fasting as of midnight. So again, we've had this problem, and it's not always obvious exactly who you have to talk to. And at these meetings, it's very important to have representatives from admitting office, from the preoperative clinic, from the floor, to be able to kind of hash out all of these problems. And again, each pathway, and at least initially, has taken around a year from design to implementation. And of course, as we've gained more and more experience and we're able to kind of apply the same principles to other procedures, this has gradually shortened over time. But overall, when we look at about 1 or 2 meetings a week per month over a year, around $15,000 in terms of time costs. And again, the development of patient education materials, we at McGill are very lucky. We have the Molson Medical Informatics group who are very specialized in patient education materials, and they have helped us extensively in developing a lot of these patient education materials. And they have estimated that the cost of developing a single booklet has been around $13,000. And again, as we do more and more of these have decreased. So when we look at particularly the colorectal pathway, when we look at all of the combined costs, it's around $110,000. So it seems like a lot, and around this Canadian dollars, so there's probably like $30,000 American or something now, based on our exchange rate. How does this compare to the rest of the world? So when we look at some of studies from Europe, so Switzerland, and a study from New Zealand, it has roughly been around the same. So in half of a year in Switzerland, it's been on $61,000 and around $110,000 in New Zealand dollars. And again, this is converted to Canadian for comparability. So how does this compare to the US though? Oh, sorry, before. And again, like we've talked about earlier, We started out on colorectal, and initially and as we know, most of the evidence is in colorectal, but we have since been able to apply these principles to many other procedures. So again, $110,000 may or may not seem like a lot of resources that are required, but when we look at the overall number of patients that we're able to apply these pathways to, so from October 2012 to October 2013, around 700 patients, give or take, were managed with enhanced recovery pathways. So when we take the $110,000 divided by around 700, it ends up being around $150 per patient. And when we look at the cost savings that our institution, and again, very specifically to our institution, have recognized based on these pathways, you see that just any one of these pathways by in and of itself more than makes up for the upfront costs. So how does this compare to the US? And again, so we know that American salaries are a little bit different. American costing structure is a little bit different. So this is a paper published out of Johns Hopkins University, and they did a relatively detailed analysis of the implementation costs of an enhanced recovery pathway at their quaternary care institution. So if we go through in detail, they've based on the number of perceived enhanced recovery cases. So in the, this is working. Oh, anyway, they use around 500. They expect around 500 cases to be managed by enhanced recovery, and if you go down the list, so implementation costs, the most important, probably the one that is very different from the data that I've just published is, again, the leadership time, and again, which they've recognized as very important, for 1 year, requiring both an anesthetist and a surgeon to be around 20% of their full-time activities to be focused on enhanced recovery. So again, your mileage may vary depending on what is existing at your own institution. That's been the main cost, so around $135,000. Capital expenses, and this is based on fluid management, the Dopplers for fluid management, buying new epidural machines, things like that. We see, again, the project manager, which, again, is very important, which is consistent no matter how many enhanced recovery cases you plan on using. They require the services of an additional acute pain nurse and additional preoperative support. And again, this will depend a little bit at your own institution. And other things that are variable costs, such as education materials, carbohydrate drinks, and other disposables. So they've determined that for around 100, if you expect to have around 100 enhanced recovery cases, the annual maintenance cost is around $100,000, and this goes up to around $500,000 with 500 cases, for an average cost of around $1,000 per patient. So, you know, that seems quite a lot, and it seems relatively different from the other studies from Canada, Europe, and New Zealand that I've shown. And when you look at the American studies looking at the economic benefits of enhanced recovery, they say that overall, on average, you can expect between $1,000 and $7,000 of per patient mean savings. So again, based on the number of cases that you plan to do, and if you can extrapolate the Johns Hopkins experience to you, overall, you still most likely will see a cost benefit to implementing enhanced recovery at those costs. And again, so how does this compare to, when we look at the available economic data from the rest of the world, you see we did a systematic review a couple years ago, and we identified 10 studies then. Since then, there's been a couple of other American studies that I've already shown. And of those 10, 8 of them showed a cost benefit towards enhanced recovery. All 4 of the American studies at the time showed lower costs, but none of them included the implementation costs. But as I said, on average, there most likely will be an economic benefit. But in terms of the European studies, only 2 of the 4 demonstrated lower costs. So why do we have this discrepancy? When you look at the meta-analysis in terms of length for enhanced recovery versus conventional care and colorectal surgery, we see on average there is an expected around 2.5 days savings in hospital length of stay. But when you compare the unit costs of a hospital day, when you look in Canada, it's around $600. In the US, At least published data shows around $1,800, and this is out of California, so again, depending on whether or not this is applicable to your own institution, and around 300 pounds in the UK. So if you multiply the around 2.4 days of expected savings, we should overall see $4,000 savings in the US, around $1,500 in Canada, and around 700 pounds in the UK. So why have we not always seen this? As I said before, a lot of the American studies have shown between $1,000 and $3,000 of cost savings. We know that length of stay has a relatively less of an impact on total cost of hospital admissions because the days that we save in hospitals are towards the tail end, which do not tend to be very resource intensive anyway. So this is a study done relatively a while ago, back in 2000. But again, when you look at how much the length of stay as a percentage of the total cost based on the overall duration, we see that it decreases over time. And we know most importantly that the main driver of hospital costs are complications. And again, they don't always correlate 100% with length of stay. You see, most importantly, you see cardiovascular tends to be around, each cardiovascular complication tends to be around $8,000 of additional costs, but you actually have less of a length of stay, most likely because the patients with bad MIs tend to just die on the spot. And comparatively, look at respiratory complications, only adds around 5 days, but has an additional $50,000 in costs. So it's not, in enhanced recovery, it's not just about decreasing length of stay, it's also about decreasing complications. And again, whether or not this is your institution will show a benefit really has to do with what your baseline status is. When you look at, again, the meta-analysis of colorectal surgery enhanced recovery, we see that a large majority of them actually, as single studies, may or may not actually show a decrease in complications, but overall, we know that through meta-analyses that we see around a 30% risk reduction. And again, this will depend on what elements of the pathway you already have in place prior to implementation of the entire pathway and what your overall complication rate is. And again, because this is supposed to be for GI surgery, this is very similar for, I've been showing a lot of the data for colorectal, but we see here for upper GI, liver, and pancreatic surgery that there is lower length of stay also in major upper GI and HPV surgery, decreased complications, and decreased costs as well. And again, when you look at this slide, the numbers tend to be a little bit all over the place. If you look at the last, so most of them show a average cost of around $25,000 to $30,000, but you can vary up to $250,000 when you look at the fourth study listed on this list. So again, costs are very, very institution specific, and it very much depends on what type of costs you're looking at and how you cost them exactly yourself. And again, just want to emphasize that the cost savings that you can see within your own institution are very much dependent on your own practice environment. What you do before, what your length of stay is, pre-pathway, what your complications, what your unit costs. And importantly, and this is something that I haven't really touched up on too much, but what is the value of unoccupied inpatient beds? Is it that these beds will just remain unoccupied, or are you going to be able to generate more revenue by having more empty beds and therefore more capacity for additional procedures and things like that? So in summary, again, time and resources are required to develop, implement, and maintain enhanced recovery. And with the new SAGES SMART program, hopefully a lot of these resources will be decreased so as you don't have to really start from scratch anymore. And based on the data that I showed, enhanced recovery may result in cost savings. It's definitely not more expensive, and the magnitude of savings will really depend on your own practice setting. Thank you.